So good evening, everyone. Thank you so much for joining us. We'll be starting in just about 30 seconds or so. This is your official 30-second warning. Okay. But want to thank everyone as they file on in from the waiting room. Thank you all so much for joining us here tonight. For those who are comfortable doing so, and again, no obligation, no pressure, but for those who are comfortable doing so, feel free in the chat to type your town or city to let us know tonight where you're joining us from. So if you're comfortable doing so, feel free to let us know in the chat where you're watching this from tonight. And I think we're going to get some more folks coming in from the waiting room, but I will get started here. Just want to wish everyone a good evening. My name is Robert Hayes. I'm the Community Outreach Librarian and Head of Technical Services at the Tewksbury Public Library. Thanks for being with us for the next hour. We have, Jason Dearen here tonight to discuss his brand new book, Killshot, A Shadow Industry, A Deadly Disease. And he's in conversation tonight with Dr. Alfred DeMaria, who's the former medical director of the Bureau of Infectious Disease in the Massachusetts Department of Public Health, and also the former state epidemiologist. I have big words tonight, okay? Before I disappear, I wanted to make 4 quick notes. First, I'd like to thank everyone behind the scenes for making this event possible. This is a collaboration between several north of Boston libraries, including Andover, North Reading, Tewksbury, and Wilmington. Second, just know that this event is currently being live streamed on the Tewksbury Library's Facebook page. I know many of you are watching us there as well. Feel free to give this video a like and please share it with your friends. Third, know that anyone who registered for this Zoom event tonight, you'll be receiving a feedback survey from the library tomorrow morning. Please let us know what you thought of tonight's event and what you'd like to see for future events. Also in that feedback survey, which will be emailed to you, will be a link to purchase an autographed copy of Killshot from Wellesley Books, which is our official bookstore partner for the event. And 10% of each sale will benefit the 5 participating libraries. Finally, just to set your expectations, I anticipate this program lasting approximately an hour. Jason and the doctor will have a discussion. Well, first, Jason's going to give sort of an overview of the book, a synopsis, and then Jason and I will have a discussion, essentially an interview, and then they'll take questions from the audience. So audience members should type their questions into the Q&A and any comments they may have into the comment box. And we'll monitor both throughout the program, but we probably won't get to the questions till about 7:45-ish or so. All right, so let me introduce Dr. DeMaria, and then I'll introduce Jason. Dr. DeMaria was the medical director of the Bureau of Infectious Disease for Mass Department of Public Health. In the past, he also served as a chief medical officer, assistant commissioner, and acting director of the State Public Health Laboratory. He has been involved in applied epidemiology and public health surveillance for over 25 years. He is a graduate of BU and Harvard Medical School. He's a fellow of the Infectious Disease Society of America and the Society for Healthcare Epidemiology of America. Lots of past presidents of lots of councils and associations as well. And he serves as a member and advisor on several committees of the Massachusetts Medical Society. And he is on the board of the Public Health Museum, which is located right here in Tewksbury, about half a mile from where I'm sitting. And then finally, let me introduce Jason. Jason Dearen is an award-winning investigative journalist for the Associated Press and was a 2018-2019 Knight Science Journalism Fellow at MIT. His work appears regularly in hundreds of newspapers and websites, including the Washington Post, The Guardian, USA Today, and the New York Times. He has twice been nominated by the Associated Press for the Pulitzer Prize. Jason grew up in California and attended the Columbia Graduate School of Journalism, and he lives with his wife, who is a law professor. So all of us here watching live on Zoom and on Facebook, and even for those who watch on demand on YouTube, let's give a big virtual round of applause to Jason and Al. And guys, you can take it away. Thanks so much.
Thank you, Robert. And it's a pleasure for me to be here tonight because this is a story that I think, the subtitle is Untold Story, but this is a story that really needed to be told, and to be told by a distinguished investigative reporter, journalist is, I think, a wonderful thing. It's a little traumatic for me, but it was much more traumatic for many hundreds of people who lived with this. And we're going to start with what is the story, Jason, so people know what the book's about.
Sure. Well, thank you so much. And the story is about the worst contaminated drug crisis in U.S. history. It starts in 2012 with the very first patients who began experiencing symptoms of meningitis from an unknown origin in 2012 in Tennessee, and then spreads like the disease did as epidemiologists and doctors became aware of it through the country in real time. I wrote it kind of like a medical thriller, medical mystery, but it's all true. And instead of the regular detective in a story, we have epidemiologists who are the investigators uncovering this as it goes on. It's also a story told from the perspective of victims, people who lived through this, both of those who lost their loved ones and those who survived. And then it travels through into a criminal investigation once the source of the contamination in the drugs is traced to the New England Compounding Center in Framingham, Massachusetts, and a federal investigation launches. And then from there, it becomes kind of a true crime story and an investigation into the modern compounding industry in the United States and kind of where we are today with the policies meant to keep patients safe from the drugs that they make.
Tell us a little bit about how this came to the attention of public health. What was the story behind those original cases and their discovery and what that led to?
Sure. Well, the first cases that came to light were in Tennessee. Patient zero, or the index case, was a man named Thomas Rybinski, who was in his 50s, previously healthy, who began suddenly experiencing dizziness and stiff neck and other symptoms associated with meningitis. But when he went to the doctor and they ran labs on him to try to see if he had a bacterial infection or a viral infection, nothing was coming back. So there was a bit of a mystery as to why a previously healthy person was suffering from meningitis. Within days, he began also experiencing a kind of rare type of stroke as well. And he was the first patient that came to the attention of Dr. Marion Kainer in Nashville, Tennessee, who is with the Tennessee Department of Public Health. And she immediately reported his case and a couple of others that came forward as well up to the CDC. And they launched a more in-depth investigation together, along with other state health departments like you in Massachusetts and others, to trace the products that were being used on these first patients and try to figure out what the source of the contamination or the source of their disease was. Was there contamination? And of course, from the title of the book, A Contaminated Drug Crisis, that they did find contamination. It was a fungal pathogen that had been injected into people's bodies.
And this fungi are tell us a little about extracillum, extrahyllum, which was the main fungus. And I think people are going to be surprised to hear that it's actually a plant pathogen. It usually is a problem for plants, but.
Right. Well, the first patient I just told you about, the index case, it was interesting. The doctor and lab professionals at Vanderbilt Medical Center in Nashville identified a fungus after some weeks of not knowing what caused his meningitis. They did identify a fungus, and it was a fungus called Aspergillus fumigatus, a fairly rare, a fairly common environmental, fungus that was known. But that species of fungus, that type of fungus, wasn't being found in the spinal fluid of other patients who were getting spinal taps. And so they thought they'd found it. They did in one patient, but then all of a sudden this mystery unfolded as to what the other patients were suffering from. Was it the same? Was it a different mold? And it would come after some weeks of searching and sleuthing, it would become apparent that Xerohilum, a brown mold that was usually only known as a pathogen on corn and grasses, had made it into the spinal columns of these victims. And, there wasn't much or anything really in the medical literature for these doctors to look at to learn, how to treat these folks. And so they, once they identified the fungus, they were able to better target treatment, but there was still a lot of unknowns because this fungus wasn't known to operate or didn't have a pathway before an injection into a person's central nervous system and into their brain.
So that's where, in particular, the CDC comes in, because they provide the expertise in these circumstances when there's an unusual cause of infection or unusual cause of disease in general. So, in addition to providing sort of the epidemiology support to follow up on this.
That's right. And, one of my favorite parts of reporting this book was tracing the kind of scientific work being done to identify the mold. And the scientist who actually ended up identifying it first was a woman named Beverly Jones in the State Health Lab in Virginia. She got a sample from one of the early patients in Virginia and set about to growing the mold so that she could look at it, and used plain water as her, as the food, the agar, to grow the mold. And she got growth and put it under her microscope. And she had recognized Xerohilum from a sinus infection samples that she'd had. She'd seen it before with her naked eye, well, through the microscope. And so she sent those samples to CDC, and CDC would later confirm her finding through their PCR and DNA analysis. So it was a great partnership, in real time with, as you know, dozens of people, hundreds of people rushing into hospitals in fear because they'd been injected with one of the 3 lots of contaminated steroids. And their medical detective work and working together allowed them to identify the mold and to get that information out to doctors working in hospitals around the country who were treating these folks. So it was a moment in the story of heroism, of good scientific work that led to a real helpful information that was able to save lives.
Yeah, maybe people don't know how these things happen, but you've had the opportunity to sort of put this on. Even at the level of the state, everybody is working on a piece and trying to communicate with, usually in those days, conference calls and emails and coordinating things. But I think to get the big picture of this in your book, what did that involve, and how did you put it all together for?
Yeah, so for me to put this all together, it was really helpful to start at the beginning and travel around and work. So I started in Tennessee and talking with the epidemiologists there and the doctors who first worked with it, and then traced it from there and followed it to CDC. They reported it up to CDC, then to North Carolina, Virginia. But the way that this was able to happen, the reason it happened, is because there are gaps in the nation's drug safety laws that allow drug makers called compounding pharmacies to operate and make sterile injectable drugs, high-risk drugs they're called, and ship them from one state around the country. without FDA supervision. So these drugs often are not FDA approved, and they're shipped out around the country. And in this case, what happened is it was one business that decided it wanted to cut corners. It had poor sterile practices, and it sent out 3 batches of some 17,000 vials of steroids that were meant to be injected into people's spines and joints. It sent them around the country to 76 different clinics. Those drugs were injected into some 14,000 patients, or some 14,000 patients were exposed to those drugs in some way. And it spread throughout the country. And the way that epidemiologists were able to kind of work together was you had the states where patients were coming forward, people are dying, people are getting sick, working with a central federal agency, the CDC, to help kind of coordinate and organize all the different various state epidemiological investigations. And so it was a really good example of kind of how the system is designed and how it can work well when it does work well. And in this case, there were, because the head of NECC wasn't initially honest about the state of his facility with you and other epidemiologists, it took some weeks to actually figure it out. And a lot of people died because of that dishonesty. But because of the hard work of the EPIs that I told you about, at CDC, and Beverly Jones, who was a mycologist in Virginia, and everybody really working together, and that system being kind of robust enough to facilitate that work, it really saved a lot of lives going into a couple of months in, by targeting treatments and getting doctors information about how they can keep people from dying by administering antifungal drugs and what doses and things like that, which, as you know, those antifungal drugs are very strong, and it matters what kind of mold it is to target those treatments. And so all that work was really important.
Yeah, those infections are treatable, but they're not treatable in the sense that many bacterial infections are treatable with antibiotics. It's a much harder thing to go through. How many people were identified as having fungal meningitis, and how many of them wound up dying?
So some years on now, the number's over 100, more than 100, so about 103 the last I saw from the count from the federal government. Some 800 people total. I've seen different accounts, like 793, I've seen 840, but right around there, contracted fungal meningitis or some sort of fungal infection in a joint or something like that. So the infection rate was pretty high, especially in people who got the spinal injections, and a little bit lesser for those who got knee injections or other joint injections. And you saw the mortality rate early on in the outbreak up near about 50%. I think it was before they knew it was a fungus, before they could target the antifungals. And then you see, as the public health system starts figuring out the source and the type of fungus, that mortality rate starts falling. Those numbers really start plummeting as in November of 2012, about 6 weeks into it, and then everyone was identified, and the outbreak was considered over by CDC in sometime in mid 2013.
And we're not even sure there could have been people who had infections that were never diagnosed, or they expired from some other cause. So it was, no matter what, it was horrendous. The numbers are huge. And could you talk a little bit? We have a question about the survivors, and it's not necessarily, it's not necessarily an infection that you survive without consequences. And many of these people to this day are having problems.
Yeah, there were many reasons why, and when I started this book in 2017, why I wanted to write it. One was the problems that were exposed during this outbreak with compounding pharmacies are still ongoing. We haven't had that big of an outbreak, but there have been a number of smaller ones that we can get into later if you want. But it was really some of the survivors and the family members of those who died that I met, and whose stories I tell in the book. look, if you got an injection that was contaminated in 2012 in one of these lots in your spine and you survived, your life was forever changed. So this is a story that is ongoing for hundreds of people who survived in the United States, and many more than that who are family members of those who died. And so it is they deal with ongoing pain. There was a long-term follow-up study that was published by a CDC doctor and some other doctors working around the country that found some 48% of the people that they interviewed who survived still suffered, debilitating levels of pain and illness. Reported, they were quote unquote cured of meningitis, but they couldn't work and lived a really difficult quality of life. And so this is something that it didn't have to happen. COVID-19 is obviously a huge pandemic, and it's a virus that we're battling right now. This was a man-made disaster. It was caused by carelessness in making drugs, and so it's a problem in terms of oversight of these types of facilities that does continue, unfortunately. And there are examples in my book that I dug up, and that other reporters have dug up, that I report as well, that show that since this happened, there have been many other compounding errors that have had deadly or other terrible effects on people's health.
So what is a compounding center? How would you define that kind of facility?
So compounding drugs is the age-old process of making medicines. One of the fun things about researching this book was learning about the history of pharmacy and why this even exists. So I really wanted to explain to people why these places exist. So in a nutshell, a compounding pharmacy, a modern compounding pharmacy, is a place that's supposed to make customized drugs for a patient. They're supposed to have a prescription from a doctor for each patient, and that drug is supposed to... An individual patient. Each prescription is supposed to be linked to an individual patient. And compounding pharmacies are really important. They exist because they're needed. There is a need in the pharmaceutical system in the United States, not only for customized drugs for people who have allergies or need specialized dosing, things like that, which compounding pharmacists can do, but also when there are drug shortages, which have really become a problem in the United States since the mid-2000s. Drug shortages for many injectable drugs, like the steroid we're talking about here, methylprednisolone acetate, many others like betamethasone, which is being used to treat COVID-19 patients now, midazolam, a sedative that is used for many different reasons, one of which intubating people, especially early on when intubations for COVID patients. And many of those drugs are currently on FDA shortage lists, which means they can legally be made by compounding pharmacies and sold across state lines to hospitals or clinics. What patients don't know is when those drugs show up and are prescribed, unless they ask questions about where they come from, it's not guaranteed that they are FDA approved or even made from FDA approved ingredients, APIs, active pharmaceutical ingredients, chemical constituents. And there are some 7,500 of these compounding pharmacies operating in the United States today, but we don't know for sure how many of them there are. And that's because they have a very effective lobbying organization that has for years resisted any attempts at registration, reporting of how many drugs they make to the federal government, reporting adverse events from their drugs. And so there's really still a kind of a lack of a vacuum of knowledge around how big this industry is, how many drugs they make, how many people get hurt from them. We know about them from media reporting, when something like this happens and it's so bad that it can't be covered up or can't be, swept aside. That's when we know that something has happened. And so it's a problem that continues today. And in terms of oversight, and like I said, there are a lot of good compounding pharmacies, and a lot of them they're needed. But if they're going to be making drugs, I believe what I've learned from reporting this book is that there is some level of oversight that's needed that doesn't exist now.
I was shocked when I got the spreadsheet of the Massachusetts facilities that received potentially contaminated drugs. And I think people should know it was more than just the methylprednisolone. Ultimately, there was a lot of contamination on a lot of different products that didn't have the same consequences, but must have had some consequence. That there was something like 800 customers in Massachusetts with 10,000 products delivered, and it was way beyond anything I could have imagined. And major tertiary care hospitals using this company.
Yeah. And
yeah.
did you know, I'm interested in this but did you know when you got that spreadsheet, did you know that why that was possible? Like why compounding pharmacies could exist without FDA registration or oversight? I mean, was that a question that had come across your, desk as a epidemiologist?
Yeah, I knew there were compounding pharmacies, but in my imagination, they were like independent pharmacies with a pharmacist in the back room making up things for the local doc. It was
like Mr. Gower and It's a Wonderful Life,
yeah,
right?
exactly.
Mm-hmm. Yeah.
Only without the drinking thing.
Hopefully.
Yeah. But this was on an industrial scale that I never imagined existed. And knowing a little bit about good manufacturing practices in the sort of the biologics arena, I said, well, they must be doing all of these things. But as you know, it was a very different experience. And I remember those calls from the investigators at the site looking into what they were doing. And the things I was hearing were, birds, fungi,
mice,
fungal growth, mice. I mean, it was astounding. It was horrifying.
Right, and the records show that they did some level of environmental monitoring, so ostensibly so they could say they did it to sell their drugs and to doctors, and that environmental monitoring was walking around the room with a sponge and collecting samples with the sponge and then growing it in a conference room, and there were records kept of that, and some of the records that I obtained through the criminal trial showed that there were mold hits that year, the year they made all these drugs, many, many times throughout that facility, including in the clean room and including on the shelf where they stored the methylpred, the steroid at the center of this whole thing. So, there was mold in that facility, and because of gaps in the oversight system, no inspector had been inside that clean room to make sure that they were doing what they said they were doing. It had been years, in fact. And at the time, and I think Massachusetts has increased its safety oversight of these facilities after this event, of course. But at the time, they had 3 inspectors with the pharmacy board, the state pharmacy board, and none, according to their testimony, were certified to go inside a clean room. So even if they went in, they didn't have the certification to go in and inspect a clean room. And so that was a problem, and it remains a problem in many states today. The state pharmacy boards are the ones in charge of overseeing compounding pharmacies. And some states do a much better job than others, but because they're allowed to ship drugs throughout the nation, that chain of safety is only as strong as its weakest links. It's a patchwork system. And so you have a lot of states who simply don't have enough inspectors to go around and make sure that these places are doing what they say they're doing or supposed to be doing. And that's why you still see people getting hurt. And the industry is still struggling to come to terms with its safety record. And FDA, for its part, can only really react when somebody after patients die or get injured, and launch their investigations then, because they don't have the legal authority to go out and do surprise inspections and that type of thing. And so we really have still, even after this terrible event that killed more than 100 Americans, and led to anger and sorrow for so many people, we still have these terrible gaps in oversight. And that's a big reason why I wanted to write this book, is is to not only tell this story of a really a great American tragedy, a monumental one, I think, but also to shine some light on this area that maybe policymakers will look at it again and say like, okay, we can do better.
It's really like my imaginary view of compounding, that the states really regulate retail pharmacies and the FDA regulates manufacturers. And these people were essentially manufacturing drugs
Right.
without any specific regulation or oversight.
Right.
And I remember,
go ahead.
I'm sorry, I just want to say, get your reaction to this. I remember, wait a minute, they need an individual, how could they have an individual prescription for 10,000 units shipped out in one day? Like, how's that possible? And it wasn't, so.
It wasn't, and there are ways that that bad actors like NECC in this industry get around that really important individual prescription requirement. One way we learned in this case, and we've seen in other cases too, is that they make bulk batches, and hospitals in clinics in bad need of these drugs. Right, I mentioned the shortages before. They take those drugs, they accept them without the individual prescriptions, they buy them from the pharmacy, and then they backfill prescriptions, and so they send names after the fact. So it's kind of a loophole, right, in getting around that. They're providing the prescriptions, but after the fact. And then the other way was they simply just made up prescriptions, as we know from this case. They made up ridiculous names like Mickey Mouse and Edgar Allan Poe and Filet-O-Fish, and there were hundreds of these kind of fake names that they just slapped on a prescription form to make it look like there was an actual prescription. But, it didn't take a seasoned investigator to figure out that they were fake.
Well, there were congressional hearings within a month or two of the onset, and there was a law passed. What happened with that?
Right. So it's called the Drug Quality and Security Act. And it, so the initial version of that law, I read all the versions of the law, very fun, and listened to all the congressional testimony. The initial versions of that law was a bipartisan bill in the Senate that was meant to give FDA what it had long sought, authority over this, like manufacturers, to put them under the FDA's umbrella, to force them to register so that we have data on the industry and that we can track them. They can be inspected in pop-in inspections, by FDA. That was the intent initially. At the time, the House was controlled by the Republicans, and a few of the Republicans who worked on this issue were, sided with the industry. They also took campaign donations from them. I know, and I report in the book. They sided with the industry, who did not want FDA registration, saw it as something that would hurt the business and would deprive patients, they argued, of the drugs that they need from compounding pharmacies. There was no indication that FDA oversight would do that, but because of the intransigence on the House side, the bill was dead. Oh, it was DOA, and the only way it was saved so that Congress could say it did something about this terrible tragedy and pass a law was to make it voluntary. And so it did create a new type of compounding pharmacy called an outsourcing facility. There are now 76 of those operating under FDA supervision in the United States. 76 of thousands of compounding pharmacies is not too many. And they surely can't bridge the gap in that we need from that industry in terms of drug shortages. And so the rest of them are under this voluntary umbrella and still rest under state oversight. So in essence, that law didn't change anything in terms of the vast majority of compounding pharmacies. They still operate in, kind of underfunded, under the oversight of underfunded state pharmacy boards in states, and still are allowed to ship their drugs around the country, even during a pandemic.
And there was nothing new here. There have been outbreaks related to compounding pharmacies and other issues with compounding pharmacies for many years before. And I presume since, in fact, I know of cases since in our own experience here in Massachusetts. So
sure,
this is an ongoing problem.
Yeah, it really is. And the people that are being harmed by this are folks, who trust in when they go to the doctor that what they're getting injected into their bodies is safe. And we know, there was a terrible case a few years back in Texas, in the Dallas area. Some 75 patients were blinded or partially blinded by contaminated eye injections. We've seen babies in the Midwest, in the Chicago area and Indianapolis, who were overdosed with a morphine mixture that was compounded, 2,800% super potent. And some of the babies were saved with Narcan, which is used, on opioid overdoses. And these types of things are common. I mean, you can look them up. CDC also has some cases since this has happened, in New Jersey, in the Northeast, all around the country, in California. Compounded turmeric injections have killed people. So it's an area that remains very lightly regulated, and unfortunately it draws criminal organizations into operating these facilities. And so not only do you see patient harm, but you're seeing billions of dollars since this happened in Medicare fraud, in TRICARE fraud, the public health insurance for military, coming from fraudulently compounded drugs. So it's a real problem in lots of different ways, not just patient health.
Big money's in the business. And people don't know what they're getting, but I don't think even the clinicians who are administering drugs really understand where they come from. They just know they need them, and they need a certain type of preparation, and it's supplied, and they assume it's coming from a safe source.
I was so surprised when I began reporting this book and speaking with doctors and asking that question. Do you know if you're giving a compounded drug to your patient or not? And how many of them said no? I expect everything I give my patients is FDA approved. So in lieu of strong oversight, the one thing I wanted to try to do with this book is I had a registered pharmacist who consulted with me on the book, and who actually inspects compounding pharmacies who want to get accreditation with the National Association of Boards of Pharmacy, which are an organization trying to make these places safer. And she wrote a list of questions at the end of the book that readers can take with them if they get concerned about this after reading the book. Some questions they can take and ask their doctor. And if the doctor doesn't know, then you can ask the hospital pharmacist, the clinic pharmacist. They'll know, and where the drugs are coming from. And it gives you kind of a flow chart of questions to ask. And if you get certain answers, you should probably shy away from taking that drug. And that's kind of where we are in the United States right now with the drug safety system. Is when it comes to certain compounded drugs, it's really up to the patient to take it upon themselves to keep themselves and their families safe by asking the right questions.
So what happened to the management of NECC?
But as you can imagine, once it came to light that NECC's drugs were to blame for this terrible outbreak, the federal government launched a criminal investigation that took a couple of years. And then in 2017, the first 2 trials in federal court in Boston happened. The owner and president, Barry Cadden, co-owner, and his chief pharmacist, Glenn Chin, were charged with various racketeering and fraud charges, but also with federal RICO murder, second-degree murder, 25 counts each. The government did get convictions for both of them, except on the murder. The jury, there was questions about that, and you can read about it in the book, but in a nutshell, the jury acquitted on the murder charges, so that even though their drugs were responsible for hundreds of lives ruined, more than 100 dead, they got about 9 years in federal prison for that. Now, the state of Michigan, which was the hardest hit in terms of the number of patients affected, they have brought murder charges in state court against Cadden and Chin. And those trials, while delayed by the pandemic, are supposed to happen later in 2021. So there is a chance that they will be convicted of murder in state court in Michigan, even though in federal court they were acquitted of it.
So there's some questions about from the audience here is about what people can do, and I think you explained that. You have to ask questions, and I think it's also there's a question about you know, how much of the drugs used are compounded and how much are manufactured, and
right. And that speaks to what I was talking about with the lack of data, because the industry has been so good at beating back any federal legislation that would cause it to register with FDA, or, you know, there have been even attempts to just try to get them to register their name so that we know they exist and send reports if there's adverse events. That's all been beaten back. It's never passed. So we don't know how many drugs they make. The Government Accountability Office, after this tragedy, did launch an investigation and put out a report in 2017. There are some estimates also from the federal courts based on various studies that you know, at least 10% of the drugs in the United States are compounded drugs now. But the sector has grown in popularity as the drug shortages have increased. And so that number could be up to, you know, 15, 20% could be more. We just don't know. We don't have the data, and unfortunately, and that's one of the you know, main gaps here. And it makes it really difficult also to report on this because it's hard for me, you know, as a reporter. I love context. I want to put something like this into context. We know these cases happen, but how often? What's the percentage? You know, just like an epidemiologist, you want to know the rate of these things. And I can't tell you that because the data doesn't exist.
I think the other thing people should realize that many drugs have preservatives in them, substances that prevent the growth of bacteria or fungi and preserve the shelf life of the drugs that in circumstances like injecting into the spine, you can't inject the preservatives. So they're compounded. Yeah,
and you know, that's an argument for compounding, why it's needed in some ways. Some people, some doctors, their practices, they want a preservative-free version of a drug. They believe, rightly or wrongly, that it can be irritative to people. Some people don't like it, and they believe that the preservative and patients do have access to compounded drugs and safely compounded drugs. But the only way to know now whether it's safe, unlike an FDA product, you know, obviously FDA approved products are far safer than products made in compounding pharmacies, if only because they're made under such strict oversight and rules that each step of the process, the record keeping, is onerous. And you have to be, you know, very scientifically sound. Your aseptic technique in those cases has to be sound. And so the products that come from that system are just going to be safer. They have eyes on them at every step of the process. Compounded drugs don't. And so, and that's where we are now. And fortunately, they don't make every product out there. They can only make, you know, certain products, either, you know, based on a prescription like we talked about earlier, or that are on their shortage list. But they still make, you know, hundreds of thousands of doses of vials of injectable drugs every year. And that's just an estimate. It could be way more than that.
This question, who comes up with the recipe for the compounded drug? Who decides what exactly goes into it, and how does that happen? So
in 1820, the United States Pharmacopoeia book came out. That was when the first one came out. And that was basically a recipe book for making medicines, for making drugs. And that's how most drugs were made in the United States for decades. Pharmacists using the pharmacopoeia, hopefully, because that was the only way to try to standardize drug making. We didn't have big pharma back then. We had individual druggists making drugs for people in their back rooms. And the pharmacopoeia was the first kind of recipe book for that. Since then, obviously, things have changed. Big pharma patents their drug formulas for their drugs. So what compounders today, what modern compounders do, is they they use generic. So when a drug comes off a patent and it can be made into generic form, that recipe is released and is available. And so compounders can use the actual recipe, but they're supposed to make it, it's supposed to be compound, it's supposed to be custom. So it has to have some difference from the commercially available version. And so like in this case, the difference was they took the preservative out. It was preservative free. So it's different than Depomedrol, which was the commercial version of the drug. And that's basically what they do. So they take the commercial recipe, the known recipe for a drug or a steroid, and they have to tweak it a little bit. They make it stronger, they make it less potent, they add a preservative, they take out a preservative. So it's just some little minor tweak. And that's how it's done today. And the USP, US Pharmacopoeia, obviously is still out there and a factor in this, but with the big pharma companies developing most of our drugs, they're the recipe makers and holders.
I was impressed that there were large hospitals that had become dependent on products from NECC, and you know, raised my mind, why weren't they compounding on site with their own pharmacy? What are the economics of compounding versus in-house or even like having a manufactured product?
Right. So you're right. Hospitals, and some still do, won't work with outside compounders. They will compound in-house. That still does happen. So that's something when you ask a question of your hospital, your doctor, they may say, we compound all of our drugs in-house. And in that case, you know that those drugs are going to be safer than outside, because in a hospital, they're going to be compliant with the United States Pharmacopoeia's rules for sterile compounding. USP 797 was the rule at this time. And that's what happened. And here's the economic kind of hinge point is in 2007, the USP strengthened, made more onerous the rules, the USP 797. And that gave hospitals a choice. We either invest millions of dollars to upgrade our facilities and get more staff so that we can be USP 797 compliant, or we outsource that job to compounding pharmacies like NECC. Many hospitals, looking at their bottom lines, chose to outsource and still do. And so that was really, it was the new USP 797 guidelines that passed in 2007 that made sterile compounding a more expensive and safer, if you follow the guidelines, practice, and got hospitals out of that game and looking to buy the drugs from a compounder who is outsourcing. And that's where NECC, that's when their business really took off. They were one of the businesses who understood that hospitals had this need. And even though you could tell from the, I got thousands of emails from the criminal trial between NECC's salespeople and hospitals, and you could see at a lot of them skepticism about what NECC was. But as soon as they said, oh, we're 797 compliant, we're very, very sterile, we have the highest aseptic technique, you see more and more hospitals, including many, as you said, in Massachusetts and some famous hospitals in Boston, and all around the country, buying drugs from this company and others. And that's still going on today. After this tragedy, the US Department of Health and Human Services conducted an audit of that I received via FOIA, the Freedom of Information Act, that was asking hundreds of hospitals in the United States if they were using FDA-approved outsourcing facilities or these independent compounding pharmacies. And a large number of them were still using these non-FDA approved compounding pharmacies. And so it's still a problem. Hospitals need these drugs. They need them. They need the, especially steroids and some of these on the shortage list. There's high demand, and big pharma's not making them in the quantities for lots of different reasons that are complicated due to supply chains and stuff. But a lot of times it'll also be just because they're not profitable enough. So they don't need to make them. Because it hurts their bottom line. And so the compounding pharmacies step in and fill that gap, which is really important, but also exposes patients to non-FDA approved
So they could be generic drugs. They could be marketed as a generic product that met the need.
That's right. Well, yeah. I mean, they're compounding pharmacies weren't supposed to be marketing
Right.
their wares to the public or anything like that. But because they successfully fought on First Amendment grounds, those limits that were imposed in a 1997 law, that the modernization of the Food, Drug, and Cosmetic Act, the Supreme Court upheld it. So now they're free to market because they have the First Amendment right to do that as a business. And so that's something that's still going on now. I mean, these businesses are very profitable, and they don't want, and have made it clear that they don't want FDA oversight, because FDA oversight means a higher bottom line, more investment in safety in equipment, and having to stop production if you have a violation, and clean, and that means dollars. And so it's a lot more lucrative not to have that kind of oversight, and it's where we are still today.
Yeah, no, I think actually, people hear about drug shortages, and frequently it is a regulatory issue with the production line is shut down until a problem is evaluated or solved, and that's part of the controls. Question here about the hospitals being held accountable. What is their liability, and were any hospitals sued for using these products?
The answer is yes. Most of the I cover mostly the criminal side of the trial in this book, and that accountability part. There were, obviously, because of so many victims, hundreds of lawsuits filed against many different facilities. And because NECC went into bankruptcy so quickly, most of those cases, and there are exceptions, but most of those cases were put together into a multi-district litigation, basically kind of like a class action, but not really. It just collected them all together to draw settlements from the bankruptcy fund and any other pools that were out there. So the answer is, to a certain extent, yes, but the courts found that NECC was mostly at fault here, that NECC bared most of the blame, and actually classified hospitals and clinics as victims in this case, because they were duped into believing that the drugs were safe. So that inculcated or protected, I guess, them for a lot of these facilities from that kind of litigation.
And what is the history? This was a very high profile case, but with other incidents that have gone on before and after. Do a lot of these wind up in court? Do these people go to jail? What happens?
They do wind up in court. When patients are harmed by a compounding error, FDA gets involved. That's when they can, legally kind of swoop in. They still, in this case, we saw, even when NECC was tied to these drugs, the FDA was asking the state of Massachusetts for permission. They were negotiating access with them because the state of Massachusetts was in charge. So yeah, you will see litigation. The company who made the morphine that I was mentioning that overdosed the babies, that company ended up, the owner and some of the executives ended up in federal court convicted. The Texas case is ongoing, but yeah, you do see federal action on these cases when they come to light. And the fraud cases have resulted in huge settlements in recent years to compounding fraud cases in Medicare and insurance fraud. So there is a lot of criminal justice activity around compounding. And let's not forget either, steroids are also used in professional sports, and compounding pharmacies have been tied to some of the doping scandals too. Alex Rodriguez, the baseball player, was tied to the steroids that he was found to have had were tied to a compounding pharmacy in Florida. So this is they have their tentacles in lots of different areas of the healthcare system, and also professional sports, and lots of different areas. So it's a very lucrative business, and a lot of that reason is just because there, if you're in a state with really lax oversight, not a lot of inspectors, and a pharmacy board that's made up of pharmacists that know the owners of the pharmacy, you see a lot of that kind of that activity in the cases. A lot of cases in Florida and other states that are known to have kind of laxer approaches to regulation.
There are a lot of physicians listening in. So the question of malpractice, to personal malpractice liability related to using these products.
I don't know of any personal malpractice cases related to this case that I can talk about with any sort of intelligence. I do know that one thing I learned is that the compounding pharmacies believed that if they, that one pharmacist told me that when she raised concerns about making a drug with a non-FDA approved API, an active pharmaceutical ingredient, she was told at numerous compounding pharmacies that she worked at, 3 different ones. And this is in the book, Sarah Sellers, who's kind of a whistleblower about this whole industry. She was told that we don't have to worry about it. Doctors are prescribing these medications, so they'll be the ones on the hook for it. So in terms of, individual medical malpractice cases, what I saw in NECC was that NECC was the one held accountable here because they fraudulently sold their drugs, saying that they were safe, saying that they were USP 797 compliant, and that a lot of the doctors and others got off without any sort of, major malpractice. Again, I don't know every doctor. There may be some out there, but in this case, it wasn't a huge issue that I saw. The doctors that I talked to certainly didn't suffer from a lot of that.
Did you find any indication that retail pharmacies, chains, et cetera, use compounding companies for products that we could go in and buy over the counter or even on prescription?
Yes. Well, they do a lot of their own compounding for non-injectable drugs. So what we're talking about, the real threat here, right, are these high-risk injectable drugs. If you have a contaminated oral medication, that contamination will probably die in your stomach acid, right? And so we're talking about these injectable drugs. So a lot of the big retail pharmacies, the CVSs, the Walgreens that I know of, they do compounding, but they do, kind of the lower end, less risky, low risk compounding. So they're doing, kind of lozenges and cough syrups and things like that, but they're not making injectable drugs. If you're getting an injectable drug through a pharmacy that comes from compounding, that will likely come from a larger compounder, not a retail pharmacy.
Someone asked, is there a list out there of states that do a good job and states that don't do a good job?
I think it depends who you ask. If you ask the industry which states are doing a great job, you're going to get a much different answer than if you're asking, federal prosecutors who are working on these cases. So the answer is no. I know that the industry associations out there, the Alliance for Pharmacy Compounding, which is the lobbying group that has advocated against all of this supervision, and the NPCCA, the Professional Compounding Centers of America, who is kind of the architect of this whole industry, the modern architect, a big chemical company that's created the blueprint for NECC and all the others. They have information about that on their websites. There's another, actually, I will amend that. The National Association of Boards of Pharmacy is an umbrella group that the pharmacist I worked with who reviewed my book, Rita Weiss, is an inspector for. They would have that information. Again, they work. They are, part of the state infrastructure. They're not independent necessarily, but it's a group that's working, I know, hard to get some sort of national compounding accreditation going, so that compounding pharmacies who do want to tell patients like, hey, we are a safe compounding pharmacy. We have accreditation. We're inviting inspectors in. We're doing these types of things to give you confidence in our drugs. They're a group that is facilitating that, and so I would think that they'd be a good place to start.
So that sounds hopeful. What are you hopeful about in terms of where the direction things are going?
Well, I'm a journalist, so I'm eternally cynical. But I do hope that this book and it starts a new conversation about this. There are obviously safety upgrades that need to happen in this country related to these drugs. So I'm hopeful that that will happen. There are a lot of people who care about this issue, and I hope that, you know, by arming people at least with the very least with knowledge that this is out there and that there's questions they can ask, that it'll make them a little bit safer. And that's a pretty simple fix, even though it doesn't fix everything. It may be a step forward.
Well, the book is Killshot, and the author is Jason Dearen. And, I think after this, a lot of people are going to get the book. And I think Robert's going to tell us how they can do that with a signed copy.
Yeah, thank you so much, Jason, and thank you so much, Dr. DeMaria. So folks, tomorrow morning, 10 o'clock, check your email inbox. There'll be a link to a feedback survey, but there'll also be a link to purchase an autographed copy of Killshot from Wellesley Books, which is our official bookstore partner. They will ship it to you within 24 hours, and 10% of your sale will benefit the participating libraries. So if we'll look for that link in the email tomorrow morning that you should all be receiving around 10 o'clock. Again, want to thank Jason, want to thank Al, want to thank all of you for watching live on Zoom and on Facebook. And for those of you that will watch later on YouTube, really great discussion. I learned quite a bit. And yeah, I'm going to probably have trouble sleeping tonight, but want to thank you both. And I hope everyone has an excellent night. Thanks so much.
Thank you very much.
Yep. Thanks, Jason. Thanks, Al. And
Good
I'm
night.
going to wrap up the call
Good night, Al.
about 15 seconds. Have a good one, guys. Thank
Bye.
you all for joining us. Great. Thanks again.